Welcome, everyone, and thank you so much for joining us for our third episode of The Rewrite. My name is Stacy Fox. I am our Chief Growth Officer here at The Garage. The Rewrite is The Garage's quarterly conversational series where we're bringing together thought leaders who are rewriting the rules, expectations, and outcomes in healthcare. So we're looking at how are you guys rewriting the game, not just the rules, rewriting the status quo, and rewriting what healthcare can become. Each episode highlights a new theme where new voices across leading industries, leading health systems are chiming in on the realities, what's working for them, what they're seeing in their different areas. In our first episode, we explored women shaping the future of value-based care. In our second episode, we actually honored our Bold Award winners across the industry. And today we're turning our attention to one of the most important conversations happening right now in healthcare, rural health transformation.
Hi, everyone, and I'm Jessica, JR, as they normally call me here. For years, conversations about rural healthcare has centered on survival of keeping the hospitals open, maintaining access for patients, and then recruiting clinicians into the RHT world. That hasn't gone away, but the conversation is definitely evolving. And right now, we're simultaneously facing some workforce shortages, hospital closures, service line reductions, financial instability, and a growing demand for value-based care. Along with, on top of that stack, expectations regarding digital infrastructure and increased interoperability. At the same time, states are also beginning to deploy funding regarding the $50 billion Rural Health Transformation Initiative. This is one of the largest investments in rural healthcare that the country's ever seen. There's no question no longer whether rural healthcare needs a transformation. It's whether the rural healthcare organizations are able to operationalize the funds before the window closes and make that transformation. Today, we are excited to have this conversation with our guests, Jody and Marcus. So I'm going to hand it over to you, Jody, to introduce yourself, and then we'll go ahead and get started.
So I'm Jody Nelson. I'm the CEO here at St. Luke's Hospital in Crosby, North Dakota, which is a critical access hospital in the northwest corner of North Dakota. So we're 5 miles from Canada and 20 from Montana. So we're really rural and in the middle of nowhere. We have 20-bed critical access hospital attached to a rural health clinic. And we also have an assisted living that we run. Our model has kind of changed a little bit over the last years. We were one of the facilities that did close our nursing home, and we closed that in 2022 during the middle of COVID. And after that, we did change 20 of the 20 beds. We did do 9 to 10 of those we use as long-term care now in our skilled nursing or skilled facility here. And then we also have a unique model here with our providers that we've been able to kind of take a locum approach, but they are now ours, but they don't necessarily live in our town. They fly in and out. So because of being so rural, we've had to be unique in that. I have been here for about 10 years. I'm born and raised in Crosby, so the community and the facility are very important to me. It's my family, my friends, and people that I've known my whole life. So that's about me.
Very good. Marcus, you can introduce yourself.
Pleasure to be here. I really appreciate it. My name is Marcus Lewis. I'm the CEO of First Care Health Center in Park River, North Dakota. Also in the north part of North Dakota, but I'm on the east side, so a little closer to the Minnesota border, but still have that general proximity to the Canadian border. We are a critical access hospital, 14-bed, and have a rural health clinic attached. We are still fairly traditional in our provider setup with an MD, family nurse practitioner, and a PA. I think the benefit for us is the longevity of our providers. Our 2 most senior providers have been here over 20 years each, one for 30 years. So to have that kind of consistency with patients and with staff really drives quality scores. You're able to adjust to the ever-changing needs of healthcare. And we've been able to change services from delivering and doing OB back well before my time to adding gastroenterology and now even employee benefits like a facility-run daycare. So as we move into the next steps, I think one thing is certain is that nothing is forever and healthcare will undoubtedly change.
Thank you. Thanks, Jody and Marcus, so much for joining us today. There's a lot of noise in the industry right now around rural health transformation because there is, $50 billion over the next 5 years tied to it. We wanted to kind of dive in and hear from you guys on the ground, the realities and the challenges that you are actually dealing with daily. I know it changes each day too. So in a month, it could probably look a little bit differently, but what you guys are actually seeing, not the version of what everyone outside of rural health is seeing, but what you guys are dealing with. So the first question I have for you guys today is, when national healthcare leaders talk about rural health today, what's the biggest misconception that they still have?
I think that the high costs of healthcare are driven from hospitals that we're simply making. And I think that misconception comes from what is a nonprofit. And then that drives the next conversation of our HTP dollars just simply coming in. And it is a very unique world where we are trying to stay afloat. And just like in the late teens, we are starting to see rural providers and rural hospitals close or be taken up by bigger systems. And that is a real fear, especially for those of us that are fiercely independent and proud of what we are doing for our communities.
Yeah, there's a list of over 700 rural hospitals right now that are at risk for closure. So that's definitely a real risk that we're all seeing.
Yeah, to piggyback on that, I think a lot of people think that rural is broken or needs fixing. And I don't know if that's the case. I think there's some great people that work in rural, just like as in urban, and we've got great ideas. Unfortunately, a lot of times it is because of lack of resources, lack of financials, to be able to do some of the stuff in the ever-changing world that we're dealing with. And so I think like what Marcus talked about, being independent is very important for us here at St. Luke's. I'm sure we'll get into this more, but one of the main reasons why we decided to band together and become Rough Rider High Value Network in the state of North Dakota to help support the reasons that we want to stay independent and continue to provide the great care that we do to our communities.
Those are all great points. I'm kind of stuck on the misconception that rural healthcare is broken. I agree. I think that from my experience and just from working with a lot of organizations in the rural area, it does seem to see that there's actually maybe better processes in place than some of the bigger network facilities, especially around communication and coordination of care, because it is a smaller network. So there is a lot more picking up the phone and calling and not just, handing a piece of paper and hoping the patient falls. So I've definitely seen that. What do you feel would be an example that you would like to share with us that, your team or your community has? What do you see as something that you deal with on the day-to-day?
I think the main thing is kind of what you hit on there too, is when you are a small facility, you can make changes quicker. And in healthcare, everything is changing and at very fast speeds. And when you have a smaller facility, a smaller team, it is easier to make those changes quicker. Whereas when you're in a big organization, it goes through multiple levels of administration before it gets approval. And we're very fortunate. I know I am, and I know Marcus has the same situation where our team is I have a wonderful team around me, and getting them to buy into what we're trying to do is easy because they can see what it's going to do for our patients, what it's going to do for our facility. So, and we are able to implement those easier. It's harder to figure out the implementation process sometimes by ourselves. And that's again where the rough comes in and has been helpful. But we can make those changes quicker, I believe, just because of the size that we are.
Yeah, I would add on to that our services come from a need. A lot of, and not every organization, but in larger systems, sometimes the ability to capitalize on income may drive a service. Our communities every 3 years get together in a community health needs assessment and say, we'd really like this. And no margin, no mission. Obviously, we're not jumping into loss leaders with both feet. Otherwise, we would be on the short end of that 700 hospital list, as you had said, Stacy. But I think we're quick to realize to do an analysis, to figure out, and as Jody said, we're quick to make that change, to implement. It's not turning the Titanic to implement a new service for us. And to be able to do that, not only are we helping out our organization, we're also helping that needs of the community that otherwise may have to drive 1 to 2 hours or sometimes even further to the nearest tertiary facility for that service. And some of these, especially oncology and some of the other services, the last thing you want to be doing is riding in a car for more than 5 minutes, and we're happy to provide that kind of quality of care.
Yeah, no, I think that's amazing. And I've seen the impact of that across a lot of organizations and just even from personal experience up here. Okay, so I'm going to ask kind of a rapid fire question based on both of your responses. What's the hardest thing right now? Recruiting and retaining talent, maintaining access to your organization, your providers, financial stability, or modernizing technology, and why?
It's a loaded question.
It really
I
is.
know.
I think they're all related.
It could
And
be all of the above. I don't
It
know.
really is. I think it depends on the issue and really the fire we're trying to put out each day. But I would say workforce is the biggest for us. You might be able to find a grant or a low interest loan to help out with equipment, to help out with building, the USDA loans, these kind of things. While some financial stability is required, realistically, if you can show break even or at least benefit to the community, but finding people to do it, qualified technicians, qualified clinicians to do the work, I think is the most challenging for us. And unfortunately, the pandemic changed the dynamic of travel and locum staff.
I would agree. I think you can't do anything if you don't have the people around you to do it. So you can buy the piece of equipment, but if you don't have the tech to run it, then what does it matter? So I agree. Workforce is always, they're the backbone of our facilities and our organizations, and they're so important, especially in the rural setting. So I would have to say workforce.
I was at a conference a couple of weeks ago, the Rural Health Innovation Summit, and one of the topics was actually around how do you retain workforce and how do you recruit? And she gave some tips on kind of what they were doing, but would love to hear from you guys. Do you have any particular tips at your system to try to help with that issue that you can share with others?
Well, a few years ago, we were struggling with nursing specifically. I think that tends to be one of the areas a lot, nursing and CNAs, especially after like the COVID, like Marcus hit on. We decided to internally do our own sign-on bonus, a larger sign-on bonus, and help with scholarships. There is some opportunities throughout the state for people to do that, but we just felt if we did something internally, we were paying such large amounts to travel that a $20,000 sign-on bonus was nothing compared to what we were paying in travel. So at that point, that was 3 years ago that we did that. We have had no travel CNAs or nurses. Well, I shouldn't say CNAs. I think we've had one CNA, but we were able to recruit nurses, and we've been pretty stable on that. So I think having your own sign-on bonuses and scholarships has been useful for us here.
I agree. I think a good CEO once said, train people well enough so they can leave you, treat them well enough so they don't want to. And we do internal, we support folks with growing internally. We've promoted executives from director level, directors from technician level, but just like they say, when you're a very good technician, does that make you a good leader? So we try to invest in leadership training and education for those directors to help give them that foot forward and drive that culture. I think another thing is the simplicity of a thank you. Whether that's in a card with a free coffee and those kind of things, recognizing National Lab Week, Physical Therapy Week. It's amazing that every department in healthcare has their own week, day, or month. And so we have a team that consists of HR, marketing, and administration that makes sure that we're not only recognizing those folks, but that we're not missing any of those folks as we do it. And that culture does bleed over. One thing I think that's unique to First Care is in our leadership meetings that we have once a month, we recognize stewards internally. So somebody that's living our mission, and that somebody could be a director, a staff. We've had patients and volunteers. Realistically, these stories are shared. In healthcare, we really focus on the 4% that we're not doing right, and sometimes don't stop to smell the flowers and look at the 96% we are doing right. And so it's been a very fulfilling and uplifting experience on an otherwise meeting where we're talking about what projects are going on and who's going on vacation next week. It adds a lot of value. And those directors then take that back and share those stories with the individual that was highlighted. And we're finding unique ways to recognize them other than assign a picture or a parking space.
That's amazing. Thanks, Marcus and Jody, for sharing. And I think even what you mentioned, Marcus, earlier about some of the benefits, like the child care center or things like that, I'm sure are helping with retaining and recruiting for you guys also. Let's go ahead and shift now into kind of how do we move from, where we're at today into transformation.
The rural health transformation, that entire funding, that bill is really kind of focusing on this transformation, really understanding that from your perspective. What does that mean for your organization as a measure of success? What is that change? What is that transformation that's operationally kind of making an adjustment? Is it a people change? Is it processes? Is it tech? Is it a combination? And how do you see that benefiting and kind of moving into these newer care models and these value-based care initiatives as part of that RHT program?
I think it's all of the above, and I hate to give you a cop-out answer on that, but realistically, anytime you add a new service, you should be going back and evaluating that after 3 to 6 months and saying, okay, what are we doing right? What are we doing wrong? And then obviously after a year or 2 years, depending on the service and the magnitude of what you've invested into it, on figuring that out. And thank goodness in healthcare, we have that annual review of services where we can go through and say, these are the cool things that we're doing that are working. These are the things we might need to tweak or maybe stop. I think that's the big measuring factor, I guess, for us. But we continue to try to meet the needs and stay around for the next 75 years is really our goal, is sustainability, and we're hoping that this program can support that.
All the changes with transformation is a nice catchphrase, but I think a lot of us are still trying to survive. One of the terms that they keep using in the state of North Dakota is they don't want us to be surviving, they want us to be thriving with the RHT funds. And sometimes it's hard to get there. We personally in our organization have had a tight bottom line always, and it's hard to get past that where every day you're just showing up to survive. So transformational is sometimes hard to get to because we can get there, but it is the buy-in with the staff, reevaluating things, addressing things, communication, all those things that happen internally, but also outside of our walls with different organizations to help those things happen.
It's funny how we get back to that sustainer, that financial. We started talking about it after the first question about 700 hospitals, and that's realistically been a problem for rural hospitals even in the state of North Dakota for quite some time. We've had a financial analysis done, I think since 2010, if I believe, and there has been at least half of us that are operationally losing money. And if it wasn't for whether that be local subsidies from their local city or county governments or donations, I think a lot of us would be in a lot worse position than what we are today. But absolutely, it's tough to see the light at the end of the tunnel when the tunnel seems to get longer every day.
Yeah, I think you guys are both highlighting a lot of the realities, right? It's how do you balance when you are still working on surviving and you're looking at days at cash on hand, operating on thin margins and limited resources. So how do you embrace even some of the funds or transformation or technology? Do you guys have something that you're very excited to launch with some of the funds that you are prioritizing when you look at transformation?
Well, for us here, this is just a minor thing, but when we're talking about equipment and services, we don't have a CT machine in a house, and which is really unique. There are maybe 2 in the state of North Dakota that don't. It's Critical Access Hospital. We're one of them. So one of the RHT funds is for equipment here. So we've applied for that. I'll be honest, as we've gotten into looking at the CT more and pulling our numbers and pulling claims and all the data part of it, I don't know how we've survived without a CT machine. And it's become very clear that we have to purchase one even if we don't get RHT funds for it. But then it, goes back to how do you pay for that? But for us, the most exciting thing with the RHT is hopefully some equipment, because then we can add some more services that we haven't. But we'll see if we get it or not.
So the most excited about, so we're going to keep this positive and happy. I like it. That's the good framing of the question, Stacy. I think I'm excited about years 2 through 5, to be honest with you. Year 1, I think there are some analyses that I think will be good for the state overall, for our organization. We have done some of these. There are some emboldened factors into wellness, and we've put some retention dollars towards wellness as well. So I believe there's some good things to happen, but we're hoping in years 2 through 5 that we can really invest in the transformational, what I believe is transformational, in that value-based care aspect, into actually meeting patients in primary care and addressing those chronic conditions and wellness in primary care. And I think, again, I know, as Jody said, I know we'll be talking about Rough Rider later, but I believe that is one of the biggest steps that we've taken collectively, is towards that goal. It is a long road, but it is one that is so necessary in healthcare. And it finally puts patients in charge of their healthcare and focuses on wellness versus sick care.
I will state on that. I was at a conference that Garage put on, and I was on a panel, and someone, I can't remember her name, but someone was on the panel with me, and she said primary care is dead. And it really, to be honest, I didn't even know how to respond to that, because that is not our world that we are currently living in rural healthcare. I think primary care is thriving, and that's where we are going to make the biggest impact on our patients and on our facilities. And that person was obviously coming from a very urban area, and they feel that ERs are going to become the next primary care place, that they already are. And that is not what we feel here at all. Value-based care, closing care gaps, chronic care management, TCM, all that, this care that we're doing for patients outside of our walls. They're not just getting care when they're in our building, but outside of our walls, is transforming our patients and transforming how we operate as a facility.
Absolutely. And the quality of care in a primary care versus the emergent and urgent care you're going to get in an ER is so much better. We've really seen it in our Medicaid population, our Medicaid and Medicaid expansion. Once they understand that those funds aren't coming out of pocket, and you don't need to show up simply when you're in pain or you have an urgent, you can come in for that wellness visit, you can get those immunizations. All of a sudden, we start to see that turning of the corner, and even just education of patients about their health care, which is really cool.
Yeah, I would love in general to see more of that wellness focus. And I think it's something that, like you mentioned just now, is patients don't necessarily understand the well part of healthcare is usually covered. So we want to see you when you're healthy, so we don't have to necessarily see you because you're sick. And I think that that's really important. And I think that, everything that you both brought to that conversation was extremely important. Having the right type of team, and a team that is willing to invest in patients and do some of those after hours phone calls or follow-ups on your patients, or care, managing those patients from a post primary care visit, I think is really important. I think that we also see this kind of push towards a more of a concierge medicine type, with like direct primary and PCP. When we're looking at kind of the short term and kind of sustainable efforts for investments, where do you see the best kind of impact versus investment for your organizations? Is it a short-term project? Is it, one thing or another for your kind of your organization or your team? Where do you see the best kind of investment going to make the biggest kind of bang for the buck in the current state that you're in, looking from those RHT dollars? If you had the ability to just say, I'm going to take the money for, what would be that bucket that you would put that in?
I think technology is one of the things, whether it be AI and scribes, but then we can go into all the garage with all that technology and data warehouses. Any kind of analytics and data that we can get is so helpful in keeping our services correct, our patients going to the right places when they leave our facility. All that plays a whole part. So technology as a whole could be, we could spend millions on that, and most of us don't have. We can get AI and help the providers out with their documentation and close those care gaps and make sure we're capturing the work they're already doing and get paid for it. But it's after the claims go out the door, what we can do with that data. We can't afford those platforms on our own, which also plays into Rough Rider, why we're together as a network.
You mean your providers didn't go into practicing medicine to chart for 4 hours after working a 10-hour day? I'm really surprised. Yeah, we've loved the AI scribes, and it's been amazing. We're actually implementing it across our behavioral health and our PT department, which is surprising. But we've seen significant increase in outpatient therapy services, patient physical therapy, occupational and speech. But I would say pie in the sky if there was no red tape. and this includes the national level, I would say investment in access to care and expansion. But the funds are very clear. You are not to build any new buildings, and remodeling, I think, has to be less than 20%. So if we take that away, because we are busting at the seams, literally, we've expanded services to the point of where we have group and individual intensive outpatient therapy, behavioral health therapy in what used to be a bed storage room. And we have a pediatric sensory gym in what also used to be a storage room. And we are well within compliance about making sure that the walls and everything are appropriate, but ultimately we maximize patient care to the nth degree. But I would say if falling within the confines of the bill and the restrictions of RHTP, I would say I agree with Jody. Technology, having a system like the Garage, really understanding moving forward with value-based care, not only holding ourselves accountable, but holding our partners accountable, and their partners being those insurance plans, because ultimately, the value-based care tech only goes as far as the collaboration does between the payer and the provider. If the payer doesn't allow for the risk to happen at the provider level, value-based care will come to a halt. If you still need a prior authorization for every service that your provider orders, value-based care comes to a stop. Eventually, to get to that full capitation or even halfway there has to be trust in the provider to take that risk for that patient. And that's where I think you've seen both the success and the challenges of the global budgeting model that we've seen in Pennsylvania and other areas. Sorry, I went down a rabbit hole.
No, I think that's great. And I would love to actually dig deeper in that rabbit hole, because I think as we have talked about the different, whether it's misconceptions and the realities of rural versus urban, value-based care, I think, lives in that space too. You hear a lot of times that I think there's a misconception that value-based care may be harder for rural communities. I feel like because you guys are so in tune with the patients and communities that it's actually the opposite. So I'd love to hear your realities for value-based care in your community, where you see momentum and kind of where you have excitement. Is there, you mentioned a little bit, Jody, in technology, kind of being able to invest even further with some of the funds. But do you think that the RHT program will also help kind of move the momentum even deeper in the value-based care space for you guys?
Well, we definitely hope it will. The reality of it is we haven't seen that yet, but I agree with it, what you're saying. Value-based care in rural it's fairly easy, because I do think our patients really want to be taken care of as a whole. They just weren't trained to do that. We were doing volume. We wanted to get them in the door, get as many patients in the door, and then see them the next week for another issue. And now when we get them in the door, we're taking care of all those things in one visit. And that's a huge change. It's a huge change for us. I know Marcus has been doing value-based care longer than we have, but it took a little bit for us to do it. But our buy-in with our staff was wonderful, because they see the value in it too. It was a different mindset for the providers, but once they had figured it out and got the idea of how it's supposed to work, we had complete buy-in from everyone. But our clinic meetings here used to be 15, 20 minutes, probably 5 years ago. Now we meet for an hour and a half once a month, because there's so many different things changing and making sure that we're, catching all this and the processes and stuff. But it's exciting to have that in the clinic, I think.
When we had our first, so we've been a part of a value-based care arrangement since 2015. I believe was when the AIM dollars came out, and then 2016 with our largest commercial payer in the state. There were about 5 or 6 hospitals in the state that took the initial leap. And yes, I would say for the first 4 years, we were participating, but we were participating by checking the box. I think with Rough Rider, we've really jumped in a little more and dug deep. I think on understanding that when you're paired with a few hospitals in California or across the country, it's a little bit different than when you have your peers that you're regularly meeting with, regularly asking advice from is important. But I do. What I found is interesting when you had said you do it better in rural. I always thought that was great when we started our patient-centered medical home accreditation, and we started looking at the measures to accomplish. We were already doing them. it was part of the basic care that they were delivering in the clinic, is knowing when your patient goes to see a specialist that they're going to follow up and make sure that that issue was corrected. And so some of these, or when they went to the dentist because they had jaw pain, was that related to it? And it was one of those things that was an aha moment to realize, hey, maybe we're doing a little more out here in Park River. And it's kind of cool. So implementing these additional strategies, implementing the huddles, implementing the tracking, and making sure we're closing care gaps really fit in well with the delivery of care that was here long before I ever got here.
So we're going to kind of flip the excitement meter here. What are you not looking forward to with rural health transformation and the dollars and the funding and the requirements?
What's keeping you up at night?
Yeah.
The requirements of it, I think, is, we aren't even at the point, we've only been approved us individually for one grant so far. So we're not even into it yet. But I think the reporting and the requirements of it are going to be very concerning for all of us. We all have small teams. We're already stretched thin. We're not getting any funds to pay for anyone to do these jobs yet. Through the RHT. And so who's going to do all this reporting monthly, quarter reporting to CMS and to HHS to ensure that we keep the funds and don't have to give them back because we just didn't report wrong. So that is very concerning for us, and to make sure that we actually, do it all correctly, and the unknown of it still.
Absolutely. I agree completely. Even just in the application process, we wear a lot of hats. Our chief nursing officer is our quality director, and we're not unique to that by any means. But that means when a new grant comes in that you don't have a hired position for, and you cannot fund with the grant, what does that fall on? Well, that falls on your CEO, your COO, your CFO, or your CNO to help draft these grants and work with it. And that's simply just to apply, let alone all the red tape, the questions and everything to do the reporting. Is absolutely, I've lost some sleep, and I don't think it's going to be any better tonight than it was yesterday. And
yeah,
I guess
that was the opposite of
say,
excitement.
Yeah, I was going to say
think
it.
that,
I guess,
it's true though. I think that those are all valid. And there's a measure of success that will be determined at the end of all of this. How would you measure it from your perspective? Is it whether the initiative succeeded because there was better access provided, there were better outcomes, there was workforce stability? Is it because we had a bigger bottom line in that financial sustainability, or was it an overall improvement in population health? Like, what would be the measure that you would want to see be kind of like, okay, well, this was a good thing. This was a good idea. It was worth all the red tape.
I think it goes back to your 700 critical access hospitals on the line. If we can get that number smaller overall, of course, we are in the state of North Dakota, but we want all of them to succeed. If that number decreases, that means the program has worked, but also I think it's services back to our community. If we keep the care here, keep our residents in our community because they have the services here, I think that's a win for all of us. Most of us live in communities that our healthcare facility is the biggest employer in our county and our city, or one of the biggest. And if we aren't here, our town probably isn't here. And so if we're continuing to bring services and keep our facilities open, ultimately, I think that is a win.
But not only short term, like at year 6, when we're all done with these funds, but at year 10. When we looked at the PRF dollars becoming an influx across the country, some of those at risk dropped, undoubtedly. But 2-3 years later, we're back up to that 2017, 2018 levels, where the Chartist Center is saying, what's going on? We got to do something. And I think that those alarm bells are ringing from right now. And how can we keep them from ringing again? I think that realistically is sustainability, because all of those other issues that you had talked to are inherent to the sustainability. If we are self-sufficient and that number's lower, we're not taking on the travel staff or workforce. We're also staying financially viable because you're not living off of subsidies or you're not living off of those donations every year. So yeah, I think I completely agree with Jody on this.
I'm
Very good,
curious
very good.
for both of you guys. We've talked a lot about, the challenges, the uniqueness of it. Are there certain things that you guys are doing to be ready for the funding? I know you guys have been so busy over the last few months. So is there any kind of words of wisdom that you guys, whether it's a capability, something to help with the tracking concerns, you can't really go higher right now. So any, things that you guys have put in place to help you be prepared to get those funds that others can, try to implement in their, different regions?
We regularly meet with our internal team. So, and we share this information. So if we get a request back from the department that says, hey, we need a little more clarification on this one initiative that you would like funding on, it doesn't simply come from a vacuum from the grant writer. Our team meets together and says, hey, that looks really good, or hey, I'd tweak this a little bit, or I'd go back to pull this market data that we pulled up with the original and maybe share a little more information from there. But yeah, beyond that, I think I don't know. I think we're riding in the roller coaster just like everybody else.
Yeah, it's really been hard because in the state of North Dakota, they don't release the grants, except maybe 3 weeks before they're due. So it's short timelines. It's a lot heavy load. We've done we've done very similar to what Marcus has done. We have a small little team that kind of our admin team is kind of taken this on, but then we've done wish lists out just because we have capital plans and all that, but even small wish lists we've done out to all staff. Please let us know, all these little things just to make sure we're not missing anything. So we're keeping lists of that too. But it's kind of by the seat of our pants right now. And you never know what next week will bring and what grant will open and how much time you have to figure out what you're going to actually apply for or not.
You guys have a lot on your shoulders. So let's kind of look at a question that we ask every guest. It's kind of one of the pieces that we look at from kind of the naming of this entire podcast is, what is the one thing about healthcare that needs to be rewritten? So what are you personally, Jody, Marcus, what is the one thing that you want to rewrite in healthcare?
I was going to say I hinted to it earlier. I think, and I've advocated for this publicly, but I think prior authorizations need to go. I think medical providers who are board certified should be entrusted to make the decisions to order the tests, the diagnostics, and the medications that are best for their patients. They shouldn't be questioned by a tech somewhere or by a family practice MD, shouldn't be questioned by a dentist or an ophthalmologist that's near retirement. They should realistically be trusted. And if any questions happen, that's what the boards that they continue to get certified and qualified under can be held accountable.
That's good. It seems small, but it is so time consuming for all of us here and facilities. Yeah. I think just that, are we keeping up with what our community needs and sustaining it and succeeding? And that's what will be if we're actually being successful.
Before we wrap up today, Jody, Marcus, you guys both talked a little bit about the Rough Rider Network. We'd love for you to share with our guests a little bit more about what that is, what it means, what you guys are doing in that space.
Sure. So in 2022, discussions started happening in the state of North Dakota for the independent critical access hospitals or rural hospitals. How do we maintain independence but stay strong? We came up and all formed, and we formed Rough Rider High Value Network. So it's a clinically integrated network, and we now have 23 facilities that are part of that. There's 37 critical access hospitals in the state of North Dakota. So of those, 23 are a part of it. Most of those ones that are not a part of it are because they're not independent. So, and coming together, Marcus kind of hit it on this earlier, but it's for the independence part. We want to make sure, many of us are fiercely loyal to our communities, and we don't want to have a larger organization come in and help us out or take us over. We want to stay independent. So that collaboration has been so important. But I'll just speak on it personally from my own bit. I've been a CEO now for about 8 years, and I felt kind of like on an island for the first few years. We were also in the middle of COVID for some of it, but being part of Rough Rider has given me so many more people I can reach out to. The collaboration outside of my office. I can text, I can call, I can email multiple CEOs. We're all in the same boat. We're trying not to reinvent the wheel, but share what we have done. Marcus has a great ACO, and he's got some really strong departments. And to have that interaction and those relationships within those organizations that are part of Rough Rider has been extremely valuable in that part for me.
Yeah, absolutely. I would completely agree. A retired CEO that was part of the initial group, but he has since retired. I'm going to steal a phrase from him when it said, "I'd like to be invited to dinner and not be on the menu." I think that's the best way to describe what the Rough Rider means as far as payer negotiations and just everything. It gives us an economy of scale that otherwise we wouldn't have. And it gives us a seat at the table, and we get to have conversations and real conversations about the benefits that we have for our patients. Because ultimately, when you're looking at a multi-billion-dollar organization, 600 to 1,200 patients aren't important. But when you put 23 of us in our attributed lives together, we make quite a wave. And I'm proud of that fact. And we're able to lift each other up and not compete with our neighbor. And that's the hidden benefit. And it ultimately is for sustainability. We are independence through interdependence is a wonderful thing. And I firmly believe in the future of CINs. The coolest part for us is before the Rough Rider, for me personally, for our organization, before the Rough Rider network, if our tertiary hospital would say, we're not going to do this service anymore, I would say, well, I guess we don't get to do that service anymore because we don't have the volumes or we don't have these kind of things. Now I can pick up the phone and I can say, hey, Jody, maybe we want to bring this up at the next roundtable, or we want to talk about this service because we're not going to have this on the east side of the state, or vice versa. And some unique ideas come up when you have 23 CEOs in that room.
Yeah, thank you guys. That's so wonderful. I think what you guys have built with the Rough Rider High Value Network is definitely, you can see it across, the industry. I think what you mentioned, even just being able to call other CEOs, what's working for you, what's not working for you. There's so much value in those conversations coming together to do payer negotiations, to be able to look at, population health and a data warehouse as one, without individually having those expenses. I know that's a big thing that you guys talk about as well. So thank you guys for joining us, Jody and Marcus, today. And for everyone listening in, we hope that you are able to take some pieces of information, tidbits. Feel free to connect and reach out to Jody, Marcus, follow them on social. We invite you to join our next Rewrite episode, and please reach out to the Garage if you have any questions.